87th Global Health History Seminar. So this is a seminar series that's nearly 10 years now. We're having them regularly here at WHO. The subject of today's seminar is universal healthcare and missionary medicine. The Global Health History Seminars were established in 2004, so it's just over 10 years, and are hosted jointly by the World Health Organization and the WHO Collaborating Center for Global Health Histories at the University of York, with the support of the Wellcome Trust. I'd also like to introduce my co-chair, Professor Sanjoy Bhattacharya, who is the director of the WHO Collaborating Center, who will coordinate the questions which will be open after all the speakers make their presentation. Today we have three speakers. It's a bit of a difference. The first speaker will be Dr. Shane Doyle from the University of Leeds. And then after his presentation, we'll have a joint presentation from Dr. Ian Smith and Mrs. Sally Smith. The presentations will last for about 25 minutes each, and then we'll have a question and answer session. And I'd like to remind anyone who makes their questions to speak to the microphone and introduce themselves, as the seminar is broadcast on the web, and so we'll have people listening on the internet. Okay, so our first speaker is Dr. Shane Doyle, who studied at Cambridge and at SOAS in London. Dr. Doyle has held research fellowships with the British Institute of Eastern Africa and the Cambridge Group for the History of Population and Social Structures. He joined the University of Leeds in 2003 and is currently a senior lecturer in African history and the director of the Center for African Studies. He's recently published a book called Before HIV, Sexuality, Fertility and Mortality in East Africa, 1900 to 1980. And he's been awarded the African Studies Association Bethel A. Ogut Prize. So, Shane, please.
Thank you very much. Okay. Thank you very much for that very kind introduction, and thanks also to Sanjoy and the WHO team here for inviting me and making me so welcome. So in this presentation, I plan to consider the role played by missionary medicine in the development of a system of primary health care in one African case study, the country of Uganda. And I want to consider the significance of this experience in terms of the future prospects of universal health coverage here in Uganda and in other parts of the developing world. So I'm asking, or trying to discuss these two questions. The first question is quite simple. The answer to it is we know the answer is yes. The second question is more interesting, and that's what I and I think Ian and Sally will be talking about as well. So the provision of healthcare for the afflicted is not something that is only a part of Christian missionization. It's an imperative for all world religions. But typically when we think of medical mission, we associate it with evangelizing Christianity. The era of the modern medical missionary began in China in the 1830s with a self-conscious goal of using healthcare to overcome cultural antagonism. It was hoped that medical mission would be viewed as a sign of good intent. It was a route into the intimate family lives of potential converts. And it was a crucial part of a package whereby Christianization was depicted as a proxy for modernization. In the decades that followed, missionary medicine became particularly associated with Africa, where individuals such as David Livingstone helped to convince secularizing European societies back home of the humanitarian instincts of missionary expansion. As the numbers of medical missionaries increased after 1900, so divergent perspectives on their function emerged. So for Albert Schweitzer, medical mission was penitential. It was a means of fighting the injustice and cruelties that in the course of centuries Africans have suffered at the hands of Europeans. Other mission manifestation of spiritual corruption, regarding Africans as inherently diseased and sinful. For Albert Cook, the great mission doctor in Uganda, medical mission, quote, deals with the problem of waste lives on a twofold basis. It has to treat the physical problem of suffering and disease, and it has to deal with the spiritual and moral problem of sin. So Albert Cook in his writings regularly wrote about Africans as suffering from both physical and spiritual corruption. The two in his mind seem to go together. The most common missionary viewpoint, though, was more functional, seeing medical mission's value in its potential to bring new souls into the church, with illness creating a captive audience for the Word of God. Often emphasized how potential converts tended to run away from missionaries. Sick people struggled to run away. It is striking, reading the sources from the early 20th century, how medical missionaries emphasized to the funders at home and to their patients in Africa their scientific and technological prowess, while at the same time attributing cures to the power of prayer and the healing love of Jesus Christ. As Africa was conquered by various imperial powers in the late 19th and early 20th centuries, so medical mission had to find a way of working with new kinds of secular authorities. Rhetorically, at least, the relationship was often fraught. Colonial governments typically felt obliged to contrast the aims of state-provided healthcare with that provided by missionaries. According to the Tanganyika Medical Department, for example, while it was concerned with the mass of the people and particularly with the prevention of the spread of disease, the missions were occupied more particularly with the individual and with the curative aspect. Scholars such as Akerele have sustained this line of argument, suggesting that a focus on curative care reflected missionary medicine's strategic interest in using healing as a route to personal conversion. So according to this depiction, medical mission was ideologically and structurally ill-suited to the achievement of universal and primary health care. Yet as Michael Jennings has shown, medical mission's curative focus in Tanganyika, in mainland Tanzania, and indeed throughout the continent, was due in large part to the inadequacy of state provision. Before 1945, in much of Africa, government hospitals and government dispensaries were almost universally located in urban centres. So for the great majority of the population, there was no state curative provision at all. In many rural communities, healthcare was provided by medical missionaries alone. Yet the implicit assertion that missionary medicine was more equitable than secular healthcare is undermined by the other reason for medical mission's curative focus. Religious institutions relied on patient fees for the bulk of their income until after the Second World War. While missions claimed that patients were never denied treatment if they truly could not afford to pay, later studies found that indeed some poor people were turned away and some poor people were deterred from going to mission units in the first place because of the potential shame and embarrassment of being asked to prove that you really were very poor. Medical mission, though, did waive or reduce fees for particular groups of patients, those defined as particularly vulnerable, are especially important to the religious aims of the mission. Where missions looked beyond the individual, they tended to focus on particular disadvantaged groups, such as lepers, the blind, the crippled, what were described as biblical manifestations of disease and misery. Maternal and child health was another area pioneered by missions across Africa. In Uganda, for example, missionaries began training indigenous women as nurses and midwives as early as 1918. By 1932, the Anglican Church Missionary Society had established 23 maternity and child welfare centres, mostly focused in central Uganda. In central Uganda, there were very few areas where you couldn't have walked to a maternity centre by the late 1930s. These clinics were tasked with improving local morality and serving as, quote, a beacon light of hygienic village life in the midst of the surrounding insanitary darkness. They had the explicit goal of improving public as well as reproductive health. They encouraged the use of latrines as much as they encouraged medicalized childbirth. Their impact initially was not so significant. Many women in the 20s and 30s were very reluctant to go to a missionary clinic to give birth. But over time, they became hugely successful. By the 1950s, approximately a fifth of pregnant women in Uganda gave birth in a mission institution, and about 40% of women received antenatal advice from mission providers. At the time, this was a really successful program. Both Catholic and Protestant missions operated an impressive referral system, channeling high-risk cases to the major missionary hospitals based in Kampala. And this was so efficient that as early as the 1930s, rates of maternal and neonatal mortality in the rural centres were as low as those that were found in England and Wales. At the time, in the 1930s, the referral hospitals were not so successful. But in the 1950s, this was transformed. As you see in this graph here, there's a huge decline in maternal and neonatal mortality, and also in stillbirths. And this was the product of a combination of new interventions, the use of the lower segment cesarean section, of blood transfusions, the introduction of penicillin, and also tubal feeding. In the 1960s, again, there's another major improvement, this time for home births. In the 1960s, mission antenatal providers focused very much on improving the hygiene of home birth. And this resulted in a similarly impressive decline in rates of neonatal tetanus and gastroenteritis. Arguably then, the distinctive concerns that shaped mission medicine in the first half of the 20th century made it an unusually good fit with some of the core principles of primary and universal health care. The equitable provision of medical guidance and treatment irrespective of gender, age, disability or place of residence, the development of an indigenous health workforce, a multi-sectional approach that engaged local communities in the transformation of health-related attitudes and behaviours in order to improve people's lives. The reality, of course, was more complex than this benign depiction. Some scholarship, for example, suggests that medical missions often associated leprosy with damnation. Missions in Uganda cross-subsidized maternity provision by deliberately grossly overcharging STD patients, many of whom, it is now clear, were misdiagnosed. In some areas, it appears that the quality of care was limited by a determination to reach the maximum number of potential converts, with Charles Good, for example, arguing that a second-rate service deemed adequate for Africans typified much mission provision. And community engagement often depended on the secular support of local chiefs or the colonial state or commercial enterprises, all of which sought the production of a new modernity shaped by hygiene and especially greater productivity. So we see here is an image of the opening of the great missionary hospital of Mengo in Kampala in the early 20th century. It's a small picture, but what you can see is some of the major colonial officials and also the great chiefs of the Kingdom of Uganda. Within this hospital over the years that followed, particular wards were named after both colonial officials and also the great chiefs who subsidized the work of the mission. Mission doctors, of course, also worked in alliance with religious and lay members of their orders or societies. Clerics, for example, endeavored to persuade Africans of the benefits of soap and ventilated housing decades before the public health campaigns of the colonial era. Cleanliness was indeed next to godliness for many missionaries. While missionary medicine has commonly been associated with the colonial era in popular imagination, the visible presence and suffering of Western missionaries in the response to the recent epidemic of Ebola has highlighted the ongoing role of church-related health workers after independence. This apparent continuity, though, conceals several changes in the nature of missionary medicine after the Second World War, not least the gradual displacement of European personnel with North Americans. One notable initiative was the pioneering work of missionary doctors in the development of rural health centres in countries such as Uganda. And obviously these were influenced by the earlier investment in the maternity centres that I described before, but the principles on which these were founded and the goals which they sought to achieve map very closely onto the Alma Ata Declaration. What was proposed by the medical missionaries in the 1950s as they were pushing for a new health centre approach was a system of community-oriented primary health care, using relatively simple technology with local community leaders helping to set priorities. The prioritization of disease prevention led to a focus on sanitation, drinking water, disease vector control, and improved nutrition. In much of Africa, mission institutions were increasingly subsidized by the state, and in many cases they were absorbed into new national health systems after independence. Even where their autonomous states survived, missionaries often sought to align themselves with the medical strategies of the state and to Africanize their institution's leadership. Yet in many cases, as political instability and economic decline affected many African countries after independence, mission institutions sought to fill gaps left by a retreating state. In Uganda in the 1970s, church hospitals and clinics, benefiting from lower salary costs and from access to external income and sources of medical provisions, expanded their activities hugely in spheres such as maternity care and vaccination. Even leprosy hospitals opened their doors to general outpatients, often becoming the only providers of healthcare in most afflicted districts during the Idi Amin era. Patient statistics from Zambia Mission Hospital in Kampala show a remarkable expansion of provision, given that the overall trend of medical attendance in Uganda in these years was sharply downward. From the slide here, you see that in Zambia, in about a decade, the number of general inpatients, of maternity cases, of operations trebled. There was no increase in personnel, there was no increase in funding in this period. In fact, they were both declining, so this is a massively overworked hospital. Outpatients grew even faster. They rose sixfold in these years. So it's very striking that in this time of the near collapse of Malago Hospital, the huge, previously very successful state hospital in Kampala, in Zambia, and it seems also Rubaga and Mengo mission hospitals took up the slack. Missionaries released from leadership positions within institutions by Africanization often turned their attention to emerging crises, playing crucial roles in care and advocacy relating to new epidemics such as HIV/AIDS. The Catholic Church claims that its medical institutions treat a quarter of all AIDS patients across the world. A recent survey questions the quality of mission healthcare across the globe, noting that institutions were often severely understaffed and many health workers were underqualified. Yet the enduring contribution of medical missions, particularly in rural areas and among disadvantaged groups, which are often neglected by the state, should not be discounted. On the slide here are images of two projects. Miriam Duggan, the leader of a Kampala-based project, and also Chitovu in southern Uganda. Both of them were founded in 1987, both by the same missionary order, and both of them transformed palliative care of HIV, leading to a very successful home-based care program. These organizations were also heavily involved in advocacy to try and reduce the stigma associated with HIV infection. In Uganda today, churches still provide 30% of all healthcare provision. Moreover, church institutions may have a crucial role to play in helping the Ugandan government to establish an effective system of universal health coverage in coming decades. In 2009, a bill proposing the establishment of a national health insurance scheme was rejected by Parliament in Uganda due to employer and worker organizations' concerns about the efficacy of the Ugandan medical system. Yet similar proposals are likely to re-emerge, given that a 2008 WHO study revealed that 29% of reported household expenditure in Uganda went on healthcare. Popular demand for a more cost-efficient system of universal care undoubtedly exists. And examples of Bangladesh, of Rwanda, of Thailand, and several other countries around the world show that it is possible for UHC to develop better health outcomes relatively cheaply. It may be that in Uganda, a new program will seek to build on the local mutual health organizations which have been set up across the country, typically by not-for-profit church hospitals, which seek to assist the poor to achieve control over their medical expenditure by investing in community insurance schemes. However, popular anxieties about the possibility that premiums will be misappropriated are lessened but not eradicated by the moral principles on which mission institutions are based. Moreover, mission healthcare may seem to some policymakers to provide a structural obstacle to the integration, coordination, and consistency that are implied by universal health coverage. The precise role that medical mission might play in the future is uncertain, but it's to be hoped that its particular strengths in palliative care, in concern for the marginalized, in crisis response, will be harnessed in the reforms that are to come. Okay, thank you very much.
Okay, well, I'd like to thank Dr. Doyle for his very thoughtful presentation. And now we have, for the second presentation, it's a joint presentation by Dr. Ian Smith and Mrs. Sally Smith. Dr. Ian Smith is the Executive Director of the Director General's Office here at WHO since March 2014. Before, he was the advisor to the Director General and also led her transition team. Previous to that, he fulfilled a similar role for the former Director General, Dr. Lee, who died in May 2006. Before that, Dr. Smith established and managed the Global TB Drug Facility in the Stop TB Partnership Secretariat. The Global TB Drug Facility is an innovative approach launched in early 2001 to secure access to high-quality tuberculosis drugs. Before moving to Geneva in 1999, Dr. Smith and his family worked in Nepal for 16 years as medical missionaries. The first 10 years were spent in a remote rural hospital and community health project before moving to Kathmandu to work with the National Tuberculosis Program of the Ministry of Health. Dr. Smith joined WHO in 1998, and he's qualified as a doctor from Leeds Medical School, where he also completed his Masters of Public Health at the Nuffield Institute for Health. Mrs. Sally Smith is the advisor for faith-based organizations in UNAIDS, based in the Community Mobilization Division of the Rights, Gender, Community Mobilization and Prevention Department in Geneva. She is responsible for UNAIDS liaison with faith-based groups and religions. She has over 20 years' experience working with faith-based organization and civil society engaged in the AIDS response, including networks of people living with HIV and FBOs, faith-based organizations from the Buddhist, Christian, Hindu, and Islamic traditions. She has worked for UNAIDS for 10 years in the Community Mobilization Unit and formerly with the Global Coalition on Women and AIDS. She provides support to civil society in a number of technical areas, including community system strengthening for treatment scale-up, prevention of mother-to-child transmission of HIV, and monitoring and evaluation. Actively engaged with faith-based communities for many years, Sally moved to Geneva at the end of 1990, following 16 years working in Nepal for United Mission to Nepal in primary health care, community health and development. She is a qualified nurse and gained her master's degree in health education and health promotion from Leeds Metropolitan University, and she is currently studying for a doctorate at Glasgow University, UK. So Ian and Sally, the floor is yours.
Thanks very much again for that introduction, and we now, Sally and I, have the challenge of trying to cover all we've got to cover in 25 minutes. What we're going to do, sorry, how do I go down here? Here we go. What we're going to quickly do is take you through sort of our experience of what it means to be medical missionaries, our experience in Nepal. Then just very briefly, as you can imagine, cover 2 millennia of medical missions. And then do a little bit about how medical missions have contributed to the primary healthcare movement and you know, what really was a precursor for universal healthcare. Focusing on 2 or 3 or 4 or 5 people who have made a particular impression on us and on our lives. And then Sal, I'm going to do those first bits, and then Sal's going to talk about her current work about asking the question, to what extent is church-led healthcare the solution or the problem in UHC, giving examples from HIV, AIDS and Ebola. So a bit of our background. This is the village where we started out our career in Nepal in 1984. A tiny village called Ampipal up in the Gorkha district, about a day's journey from Kathmandu, the capital. It took about 6 hours by bus and 6 hours walking to get there. Everybody had to walk. There was no other way. So if you were sick, you walked, or you were carried in some way to get to the hospital. This village is also about 6 days walk to the border with Tibet, and it covered the area we were working in. The hospital that we were working in covered that whole area. So we would get patients coming in to the hospital here, 40-bed hospital. We get them coming from as far away as 20-odd days walk in some instances. I remember seeing a man with a TB of the knee who'd taken 24 days, I think, to walk to the hospital. We imagine giving a month's supply, saying go home and come back in a month. Not really going to work. We started out working in there, and then we moved into the area that we really were most interested in, which was in community health and development, and led the community health program, which served an area of about 25,000 population. Three main streams of work in that program. The first was on maternal and child health, and we were training village health volunteers and working with communities to establish local maternal and child health clinics, doing basic nutrition, immunization, etc. We had another stream of work around drinking water, or rather safe water, gravity flow water systems, which had a profound impact on communities, particularly on women, not just because they then had a plentiful supply of fresh water and clean water in the village, but it also meant they weren't spending 2 to 3 hours a day walking to the nearest water source to collect water. And most exciting, we had a non-formal education program working on female adult literacy. Working with groups of women in the community. They established themselves as groups, which started out as literacy groups, but then usually went on to become things like savings groups and stuff like that. But most really fascinating part of this was that this group of women that you see here are a group of women from the Gurung community, the Gurung tribe, who don't speak Nepali. They speak Gurung language, which had never been written. So there's no way of they didn't have anything to work on literacy with. So what we helped them do was actually write their language in the Nepali script and then produce their own materials. So they would actually print the materials locally in the village. We helped them build silkscreen printers. So they would actually develop their own learning materials and use them. Fascinating work. After a few years working on that in around 1991, I started to move more into tuberculosis control at the request of the local government to work to support the whole of the district on TB, and we eventually moved over to the district capital to work with the district health office on a TB control support program, which was basically me and one other person supporting the government workers with training and supervision and follow-up and so on, and sometimes going out into the community to see patients. The lad on the right there has got a very severe case of scrophula, of TB of the glands of the neck. I saw him 6 months later, and it all cleared up fantastic, and he was there back in school. The guys on the left are part of a training program that we were doing with both health workers but also with the community. And then a few years later, in '94, we moved to Kathmandu to work with the National TB Centre. I was there. Sally was working on HIV/AIDS with establishing an NGO, a local NGO in Kathmandu to work on HIV support to other organisations. I worked with the National TB Centre, and I was actually seconded. I was quadruply seconded. It may sound a bit daft, but we were with the Baptist Missionary Society, who had seconded us to their umbrella organisation in Nepal, the United Mission to Nepal, who had seconded me to the World Health Organisation, who had seconded me to work with the national government. So I had 4 bosses, none of whom knew what I was doing, which was best possible situation. And then as you heard at the beginning, in the end of '99, we moved here, and those are the cherry trees from when they were a little bit smaller, and have been here since. So that's our history of medical mission. I mean, when people might ask, well, when did you stop being a medical missionary? Yeah, good question. I said I'd cover 2 millennia. Well, here's the start. These are the words from Luke chapter 9, verse 2. Jesus, he sent them out to proclaim the kingdom of God and to heal those who are ill. A missionary simply means one who is sent, and the first medical mission of the Christian era is recorded with these words. Most appropriately, written by Luke. Luke was both a historian and a physician. He wrote not only this gospel, but as you probably know, he also wrote the Acts of the Apostles. Salvation and health are integrally related in the Judeo-Christian faith, and the emphasis on wholeness, as we heard earlier, has contributed to this persistence of an integrated, patient-centered approach in faith-based care more generally. There are obviously exceptions, leprosy, HIV, etc., but those are usually driven by a concern for a particularly vulnerable or stigmatized group in the community. 2 centuries of modern medicine. Well, when did modern medicine first start? I'm going to position it for the purposes of this discussion around the development of vaccination, of inoculation, and I mean it's arguable, but modern public health certainly seems to have really taken hold from that era. In 1796, Edward Jenner here inoculated the 8-year-old boy James Phipps with cowpox to protect him successfully from smallpox, and a couple of years later published his paper on the potential for inoculation. And it was only 4 years earlier, in 1792, that William Carey, who formed the Baptist Missionary Society, the missionary society that we went out to Nepal with, he formed that and went out to India, initially to Calcutta and later to Solampur, to establish a mission station there. And effectively he's often named as the founder, or as the father of modern missions. He went out with a person who's much less well known, Dr. John Thomas, on the right there, who was a medical missionary, and it was actually going out as supporting that work on medical mission that Carey went out. Now, obviously, I'm saying two centuries of modern medical mission. That ignores a vast history, particularly of Catholic missions activities. So this is a little arbitrary, but Carey is often viewed as the founder of the modern missionary movement. Clearly there have been criticisms, we heard some of them already, of the missionary movement and its links to colonialism. Many missionary societies were formed in Europe and North America around this time, with, as we've heard, a focus on proselytizing and on Bible translation, but quite a few also with a strong focus on health and social reforms. Carey, for example, was very strongly involved in opposing the practice of infant sacrifice and sati, and self-immolation by widows in India. And Livingstone, here pictured, he's a medical missionary. He was a Scot, an explorer. His motto, which is on his memorial, I believe, in Blantyre, was Christianity, Commerce and Civilization. And he saw this as an alternative to the slave trade, which he was following the slave trade routes, but trying to establish an indigenous economic trade route that would replace the slave trade and correct the inequitable balance between Europeans and Africans. A few people who've made a difference in our lives in terms of their influence in individuals in medical mission. Well, first, somebody who's played an extraordinary role in medical education, particularly in Asia, particularly in India. This first lady in the centre there is a lady by the name of Ida Scudder. And she was a third-generation missionary doctor and went to India in 1899 and opened a small clinic in Vellore in South India. She had originally trained at one of the few medical schools in the US, in New York, that took women, that trained women, accepted women students. And she quickly recognized that there was an immense need in India for trained female doctors to respond to the needs of female patients. And she initially, around 1900, started this clinic, and then she started a medical school in 1918 in Vellore. It later became the Vellore Medical School, and eventually that medical school became the Vellore Christian Medical Centre as it is today. From the beginning, it only took women to train as doctors. It wasn't until 1945 that it actually allowed men to come in as students of medicine. It's trained tens of thousands of doctors who worked in India and across the world. An extraordinary, and it continues today, an extraordinary place. I think it's the largest Christian hospital in the world. Another person who's been extraordinarily influential for us and for many others. Anybody know who that is? Apart from Shane. Oh, yeah, that's true. Never mind. Apologies. Maurice King. Maurice King wasn't a missionary, but Maurice King was working as a lecturer in microbiology in Uganda in the mid-1960s, when he was asked by a missionary friend, Dr. Peter Cox, to cover for him working in a remote mission hospital in Amadat in Karamoja in Uganda. Now, the other interesting link there is that Amadat was where my godmother was also working with Peter Cox, so that's the other sort of link into this. Following that experience, he organised a conference on health centres and hospitals in Africa at Makerere, where he worked, with the support of WHO and UNICEF. And it was out of that conference that this book came. As I said, he wasn't a missionary doctor, to my knowledge, but it was his experience in working in a mission medicine and mission hospital situation that stimulated him to organise this conference. And if you go to this book, this was I don't know if any of you have seen this book or read it, but when we first went out to Nepal, this was the this is what everybody took as their basic guide to working in health in a developing country, in a hospital in a developing country. And if you look at the participant list at the back, you'll see the extraordinary number of mission hospital doctors and nurses and health workers who contributed to that document. Quite an extraordinary book. An extraordinary man. Here's another extraordinary man. Yeah, David Morley, quite remarkable man, sadly died. He went as a medical missionary to Nigeria with the Methodist Missionary Society, and he started a series of under-5 clinics there run by local people. He trained local women to immunize children. He introduced measles vaccine. He devised, what he's probably most well known for is the Road to Health growth chart. Which you see there. Many of you will, I'm sure, have seen these Road to Health charts. That Road to Health chart belongs to our daughter, who we adopted at the age of 11 months when she weighed, 3.2 kilos, as you can see there, so grossly malnourished. And you can see her trajectory of growth following her coming to us. She was gaining 100 grams a week. So it just demonstrates the extraordinary, 100 grams a day, the extraordinary value of the growth chart. We've seen it ourselves. But David Morley played a critical role in that, and as you know, then came back to the UK, worked in the Institute of Child Health in London. We went on one of his training courses that he organised there. Quite a remarkable man, and made a major contribution to child health. Final example of people who've made a difference. This remarkable couple, two great heroes of community health, Raj and Babal Arola from India. They trained at CMC Vellore themselves. They qualified, I think, around 1960. And they created and launched the Comprehensive Rural Health Project in Jamkhed in India in 1970, which again I'm sure many of you have heard of. Probably one of the most influential and most significant models for community development, not only in Asia but worldwide. And Jamkhed continues. It's actually run now by their daughter. They both sadly died themselves, but they really launched an organisation which was focusing on empowering communities to eliminate injustice through health and development. Quite remarkable people. Health and medical missions and universal healthcare. My last slide. Many of you will be aware of the significant and profound interrelationship between the work of the Christian Medical Commission and WHO in development of the primary healthcare movement. I think it's fair to say that the primary healthcare movement of the 70s had its roots very firmly in the experience in medical missions. Medical missionaries have been influential in promoting the training of village health workers and access to basic medicines, but by the 1960s there were significant concerns that that traditional approach to missions through hospital-based care was really failing to meet the needs of many populations, and the increasing costs were unsustainable. So it was in 1968 that the World Council of Churches formed the Christian Medical Commission to explore what specific or unique contribution to health and medical services could be offered by the Church. That following year, actually, CMC became an NGO in official relations with WHO, and including in its application a description of its philosophy of comprehensive healthcare, which it described as a planned effort for delivering health and medical care, attempting to meet as many of the defined needs as possible with available resources and according to carefully established priorities. One of the most significant outputs from the CMC was this magazine called Contact, a journal, which was probably one of the first places that the term primary health care was used in its current meaning. And it was extremely influential. Just looking at the titles of some of the issues that they had in the subsequent years, the future concept of comprehensive healthcare, as I mentioned, in June 72. In 75, they did a series on primary healthcare and the village health worker. Healthcare for all, the new priority, in April 1975, echoes of health for all, in fact pre-echoes, I guess, of health for all there. Health attitudes and values, the hospital and society, from June 75, and then August 75, is primary healthcare the new priority? And it was a question, yes, but. CMC was incredibly influential in the development of the WHO primary healthcare concept. John Bryant and Carl Taylor, who were two of the main architects of PHC, they were members of the Christian Medical Commission. And the third, Ken Newell, in writing the book, the foundational text, Health by the People, he used many examples from the CMC health programs. Interestingly, Ken Newell's father had worked in the World Council of Churches. Not surprisingly, also to note that Hafton Mahler, the leader of this, who launched the primary healthcare movement in Alma Ata, he is the son of a Baptist preacher. So some fascinating links between medical missions and UHC. So let me hand over to Sally.
Thank you very much. So thank you for your introduction, thank you for your welcome, and to colleagues for joining us this afternoon. As many of you have realised, I'm married to Ian, so I'm the other half of this partnership, and and that was our daughter's growth chart that you saw. So when Ian came here to work with the World Health Organization, I also came, and I've been working for the last 10 years for UNAIDS as their advisor on working with faith-based organisations. So I'd like to make a bit of a leap and try and connect some of those dots. A couple of weeks ago I was at the meeting of the African Christian Health Association's conference in Kenya, and their title of their consultation was Universal Health Coverage. The three people pictured there are, I would say, some of the modern heroes of medical missions. They probably wouldn't call themselves missionaries, but they're all nationals of their own countries and serving their own continent in the most extraordinary ways. Karen Sichinga is the Executive Director of the Christian Health Association of Zambia. Samuel Mwenda is the Executive Director of the Christian Health Association of Kenya. And Mwendo Kazadi is one of the leaders of the 9-country HIV PEPFAR program that's provided HIV treatment across 9 countries in Africa for many of the last 10 years. They've just given such an outstanding service to their own people with a motivation from their own faith. So kind of like to join some of those dots. It was actually Sam and Kazadi's birthday, so they were having a celebration on that occasion. But I wanted to join the dots between what Ian was just saying about the CMC and the Christian Health Associations, because over that period, there was a massive change between the independence movement of the 1960s and the simultaneous movement to indigenize churches as the colonial powers moved out of Africa and many of the indigenous governments took over. That was paralleled with the establishment of many of these Christian health associations in Uganda in 1957, Ghana in 1967, Zambia in 1970, and Sudan in 2008. And now there are many different models of a Christian health association across Africa. They're also reaching out to draw in some of our Islamic colleagues who have associations across the African continent and trying to bring together an interfaith network. But the period in the sort of 50s, 60s and 70s was characterized by a change as there was a decrease in the numbers of external medical missionaries from the West, from Europe and America, a decrease in external church funding, but an increase and a gradual shift to national management, and an increased reliance on project and donor funding, which then changed the nature of some of the work. This is from the Christian Health Association's website, and ACHAP, the African Christian Health Associations platform, now has around 28 Christian health associations covering approximately 14 countries in Africa. And I want to recognise Dr. Manoj Kurian, who's here today, who's worked with the World Council of Churches for many years and has been one of the chief liaison points between the African Christian Health Associations platform and the work of the international organisations here in Geneva. But there's a long history of the religious organisations' involvement in health and social care, and the religious health aspects provide significant proportions of national health assets in many countries, particularly across Africa, and they make a strong contribution to the HIV response as well as other responses. But one point I want to make, and I keep on making it in many settings at the moment, is that a national response is bigger than the government-run health service. And a national response includes NGOs, it includes the faith-based sector, and it includes communities, people living with HIV. And if we only focus on what the national government provides, and we don't strengthen that infrastructure, particularly in a context, as we've got right now around Ebola, where we're scaling up infection prevention control through the government health services, if we miss out on those Christian health associations who might have a hospital right on the border with the country next door, next time you have a case coming across the border, that's going to be the hospital that will receive that case first, and if they're not part of a national strategy to strengthen then that protection, then there's your hole in your national system. So they are both a huge national resource, but also they can be a gap, and I think those are some of the things that we've been struggling with both in the HIV response, but also as we've engaged with you in the Ebola response. So one of my questions was to look at some of the perhaps the controversial issues. To what extent are FBOs a part of the solution and a part of the problem? And within the HIV arena, HIV has exposed the fault lines in society in ways that TB and malaria and some of these other diseases don't. It's brought up apparent contradictions between the traditional interpretations of theology and religion and more recent approaches to public health, particularly around HIV. So as the advisor on faith and religion, I received reports from a UNAIDS country office in Africa where a gay activist had just been arrested, and the national network of newspapers had published a newspaper entitled Cage the Filthy Homos, arguing that the homosexual people were no better than dogs. And so there was here an inherent contradiction between some of the religious activism putting pressure on the government and the implementation of a public health response, at the same time as we're trying to get that government to integrate the services provided by the Christian hospitals into the national response. So you've got very, very difficult situations of both the political tensions and the need to scale up service delivery. So these are just some examples from the last couple of years in Uganda, and interestingly, there are two photographs on the newspaper page there. One of them is David Kato, who is now sadly dead. He was murdered following the expose of what were seen to be gay activists in Uganda. And the other person is a bishop who has stepped out of line with some of the other bishops in his country and provided support and spiritual care to gay people, and has been victimized. He's still alive, he's not been attacked, but he's been the victim of hate mail and quite a lot of hate attacks as a result of his trying to reach out to provide spiritual support to that community. So again, just an example of where these things come into conflict. Another one is the Commission on the Status of Women, which failed to agree on wording because of the concerns expressed that religion religious sensitivities and traditional values would be upset if we included language around sexual and reproductive health and rights. And the government of Norway spoke out in 2012 and said, we cannot, whilst we want to protect religious freedom and cultural diversity, we cannot accept that religious and cultural and so-called moral arguments are used to block decisions, avoid obligations that would give millions of women freedom and save hundreds of thousands of lives. So I'm not saying what's right and wrong here, I'm just trying to point out the controversies and the way that some of the religious issues are driving policy as well as service delivery. Another one, a couple of controversies and contradictions. The theological operative to care for the sick and most marginalized and vulnerable, often arising from a salvation theology of raid and rescue, has led to many orphanages and rescue attempts on sex workers. Those, again, are contrary to some of the best practice around the Joint Learning Initiative on HIV in Children has articulated that the best place for children to be brought up is in the extended family, not in an isolated orphanage. And many of the sex workers would be outraged by the idea that they need rescuing. So what are the issues here, and how can we help to bring some common ground between the needs of what... start again. Where can we bring common ground between the theological understandings of human dignity and the basic imperatives of human rights, much of which have a very common root? So some of the work that I just wanted to quickly outline some of the ways that we've been working with faith communities in UNAIDS to try and address some of those issues. I outlined what some of the problems are. There's many, many more. But there's also a great strength in what the faith community brings, and we've seen that. So we have, much of the work I do with partners, we have 6 main areas. One is to work together with high-level religious leaders on advocacy, to actually demand change, to demand sustainable resources for healthcare, and to address some of these issues. And what you see there is our director, Michelle Sidibe, at the High-Level Religious Leaders Summit on HIV, meeting with a Hindu leader, and Canon Gideon, who's the first openly HIV-positive religious leader in Africa to declare his status. And a march there at the Washington AIDS Conference, these 2 religious leaders, one of whom is openly gay and is campaigning within the church within America for acceptance of gay priests. Addressing controversial issues such as human rights and sexuality. We also work on gender-based violence, together with religious leadership and communities. We engage with faith-based service providers, trying to scale up the service delivery and prevention. We try to work on building the evidence base and building the capacity 2 ways of the faith-based community to engage with the public health community, but also the behaviour change that is needed within the public health community to engage effectively with the faith community. So there are a couple of opportunities this last year to counter some of this very negative religious rhetoric that's coming out on the floor of the policymaker in making arena in New York. UNFPA worked with UNAIDS last year to convene a dialogue in the UN itself with religious leaders from all faiths, and they came out with a declaration which is very powerful, saying, "Not in our name." And again, when many states are saying we can't offend our traditional sensitivities, the religious leaders said, please do not use our name. Not in our name should any mother die while giving birth. Not in our name should any girl, boy or man be abused, violated or killed. Not in our name should any girl be deprived of her education, be married, be harmed or abused. Not in our name should anyone be denied access to basic health care. And they've gone on to list a number of things there to say this is not representative of full religious belief. Let's make sure we don't use it as an excuse to undermine public health. And the second picture there is of Michelle Sidibe with the Archbishop of Canterbury and 2 archbishops from South Africa launching the We Will Speak Out coalition, where religious leaders are speaking out against domestic violence and providing safe spaces for young women who've been raped and abused within church communities. Again, part of building the evidence base is to document the work of the faith communities, working in partnership with the World Council of Churches and others, documenting the extent of the service delivery and getting a mapping of where those facilities are, so that in situations of crisis and conflict we can reach out and engage those networks. The Lancet is putting out a series that will be released in Washington this year in July that will document some of the work of the faith-based organisations, and also has an article on the controversies. So it's looking at both the service delivery and some of the controversial issues. The World Bank put out 2 monographs, again, trying to document some of this evidence over the last couple of years. I think one of the issues that we grapple with all the time is that whilst we know that these services are provided and there's a lot of services that we need to engage with, because of the ideological challenges and those clashes, that's partly what keeps it below the radar and means that there's a reluctance on the part of international organisations such as our own and the governments to engage with communities that sometimes can be seen to be politically very volatile. Yet in achieving universal health coverage, I would suggest that we've got to get beyond the ideological clashes in order to rope in the health service delivery facilities and make sure that services provided in those facilities are stigma-free and that they are provided to everybody. Just a couple of quick slides now on our recent experience around Ebola. Have I spoken too long? Yeah, shut up. Just to make the links between HIV and Ebola, the guy with the T-shirt is from the National AIDS Centre in Sierra Leone, and his T-shirt says, "Prevent infection, go for treatment and stop stigma." Some of the strengths of both HIV and Ebola. And the two ladies there were at the National Council of Churches, the Regional Council of Churches meeting, Isabel, for Ebola prevention across the region. One from the Ghana, so it's Christian Health Association, and the other from the network of people living with HIV. Again, trying to build the capacity of church and hospital networks across Africa to preparedness around Ebola prevention. I'm going to have to speed up and move forward. Another lesson that we've learned from the HIV response is the importance of including people living with HIV. At the bottom we have Phumzile Mabzila, who's the leader of the African network of religious leaders living with and personally affected by HIV. He's a fantastic advocate for women's rights, gender equity, HIV, and the involvement of women in policy making. And at the top we have the young lady from Nigeria, Dr. Alma, who was a survivor of Ebola, who came to the World Vision's regional training on Ebola, using the curriculum and the religious leaders they've trained for the last 15 years on HIV to mobilise that religious leadership around Ebola prevention. And we invited the lady doctor who survived Ebola to come and talk to them about her own experiences. Again, modelling that on the experiences of including people living with HIV. WHO here realised the importance of a safe and dignified burial protocol, and that was the point at which I came to work with Pierre Formenti and his team to reach out to some of the faith communities and expand that safe burial protocol back in October, November of last year to include religious perspectives and to move from what had become in some people's minds dead body management to a much more safe and dignified approach and draw on some of the theological and the traditional practices that could then be adapted at a national level so that people could stay safe but keep their traditional practices. And again, we've had some discussions around to what extent is community resistance a result of our own health systems and transigence. But when we actually rolled that out, I've condensed this into about 2 seconds, what was the sort of 2 months process. But it was quite an extensive process of consulting with religious leaders from both the Islamic faith and the Christian faith, including the Organisation of Islamic Conference, Islamic Relief, the World Council of Churches down the road. We together drafted a couple of additional pages for the protocol. It was sent to the countries who had a chance to have a look at it, provide feedback, and then it was finalised and launched. But when the religious leaders, I went to Sierra Leone a couple of weeks ago and met with the Interreligious Council, and this is what they said. The safe and dignified burial protocol was a game changer compared to the situation beforehand, which was characterised by tension, violence, secret burials and pelting with stones. Involving religious leaders calmed fear. It provided a rationale to people to change, to take up new burial practices and adopt an alternative. There are still some burials in the community, but much less so. And controversial aspects before we had this protocol, there were controversial aspects before this protocol. Before that we had no separation of male and female bodies, and that's much better now. The moment when the epidemic turned in their country, when you turned and talked to us, that was when things changed. I know that we have many other public health interventions right at that same time, which were also very instrumental in turning the epidemic around. But it was interesting to hear their perspective on that. I've talked too long, but thank you very much. And here are two of an Islamic and a young Christian lady, both from the World Vision training, who've gone back to their countries to work with their own communities on both Ebola and HIV. Thank you.
Hi, I'm Sanjay Varacharya from the University of York, and I work with colleagues from the WHO through the WHO Collaborating Center for Global Health Histories. So if I could just reiterate my colleague Human's request, when you ask questions or make comments, please speak into a mic and please identify yourselves, because there are people online who may want to continue discussions with you. The event is also being recorded and will be put on a database which has many more GHH seminar recordings, which we provide for free access to anyone who's interested. So I have questions, but I'll keep them for the end. Are there any questions, comments for our three wonderful speakers from today? Sir, if yes or that, yeah.
One of the questions, I don't know, maybe it's a question of observation. I think. My name is Shambhu Acharya and I work for WHO and Ian is my boss. There is the question that you discussed about not really acknowledging the response that the faith-based organization give in the national program. I think it's something, I guess, also I really noticed that because when we did the country cooperation strategy in some of the countries that you mentioned, the Uganda, Liberia, Sierra Leone, and when we did the consultation, we found out that around 10 to 25% of health services was provided by the faith-based organization, particularly the primary health care services in those countries. Yet, I think we look at the National Health Plan, there's hardly any recognition and the policy. I think it's not only that there are some political sensitive issues in my view, but also what happens is that I don't think there is enough effort to really include this private sector and the faith-based sector in the National Health Plan itself. And that's not only in the case of Africa and also not only in the case of faith-based organizations, but also as a whole, even in the culture of WHO, I think when we go and provide the support, I think we tend to get most of the time in the National Health Plan and policies, particularly the public sector services. I'm not including that. I think the services that are provided by other areas, including the faith-based, and I think is very, very useful. And it was very inspiring for me because to know from those three countries' experience that I had, I think the faith-based organizations have done a wonderful job in terms of providing services, which should be adequately reflected in the national health policy and plans. Thank you.
Would you like to respond, Sally, or?
Thank you, Shambhu. Of course, I have to agree with you. That's what I'm always arguing for. But I think there are different modalities and mechanisms, and we need to look at how it will work. There's a number of the Christian health associations that already have memoranda of understanding with the national government, and some of those work extremely well. In other government settings, in other country settings, those have not yet been established, and I think you can look at models of how to replicate those in different countries. And I think another model is the 3 1s of the AIDS response, where you have a national partnerships forum, which enables you to then have the national plan, the national monitoring and evaluation strategy, and the partnerships forum, which brings together both the state-provided services and then the NGO sector, the FBO sector, and others who provide private sector who provide services at a country level. And I think it's easy for us to lose that, but it's actually a mechanism that we've established in the public health arena that I think could be quite helpful in moving forward with universal health coverage. Thank you.
We used to work with WCC. Thank you very much for this, the presentations. I think it's very critical, and just want to raise an issue of change of personnel. What happens is in the government systems and in the FBO sector, people and even leadership, they change. And so there's a need for ongoing discussions on these issues, because people who are, and if there is no systemic linkages with of cooperation, then it goes off with the people who know these things. So a lot of cooperation actually depends on person-to-person contacts, and so we need to make it clear. And of course, people need to move. Even in the faith sector, there is an exclusive approach. They look among themselves. So the country level Christian health association or interreligious health associations are very good, so they can start. They're doing this, but there is a need for greater leadership from WHO, where you need to challenge the countries, because and of course it's an intergovernmental body, but it is to the interest of the countries that they actually get all the service providers who are providing the service. And so and knowing that people move on, and there's a tremendous change in personnel, and so you can't depend just on the goodness and understanding of people.
But so is it something you see only in relation to WHO, but other UN organizations as well?
I mean, in health, of course, WHO is a tough organization to deal with because it's a technical organization. So it is actually, even in organizations like WIPO and UNAIDS, etc., they're a little bit more open. So because it's a technical agency, WHO can actually hide behind technical walls. It's not as it's an important thing that it's technical, but that you need to be aware that it's just not that you cannot just be get everything from the governments and say that's it. I'm not saying that the other sectors are great. There are a lot of issues, but it's issues of mutual dialogue and challenging each other. But of course, WHO, we have formal relationship, and we have all these faith sectors like not only WCC but also Caritas and many organizations have formal relationships, and Medicus Mundi. So we try to organize ourselves to relate to the best, but but WHO needs to be more proactive in raising these issues. And in many ways, people like Ian and Sally and all these are greater champions than ourselves. So a lot of change can happen only from within if these champions are there within your system. Thank you.
The divisions between religions are very striking and very important. So I was thinking about, this is a question for Shane really, I was thinking about what you were talking about in Uganda, that the divisions between different Christian churches in the early missionary days in Uganda were very important and led to strife and bloodshed at that time, that sowed the seeds for continued strife and bloodshed really ever since. So I was thinking about the divisions between different religions in relationship to how they affect the type and scale of health service that the different religions get involved in. So it strikes me as curious that one group of religionists should support one sort of health activity and another group of different sorts or not at all. So how do those divisions in religions affect the differences in the scale and type of healthcare that the religionists might get involved in? I should have done that at the start. Dermot Maher from Tropical Diseases Research.
Very interesting question. Uganda is unusual in many ways. One of them is that there were only two major religions which were active in Uganda during the colonial period. So it was Anglicanism and Catholicism. So what you have then is this bifurcated political system, bifurcated educational system based on the missions. The health systems are based on two missions which compete. So it's a truism that you find mission organizations locating institutions next door to each other to compete for local souls, and it has resulted in growth inequities over time. It's not a very logical thing. It's one of the main criticisms coming from the secular side. Uganda has had a history of religious strife. The two major political parties of independence were religious-based parties, and that did lead to the extreme conflict of the late 60s, 70s, 80s. You asked about the ways in which these two different religions, or how different religions shape the kinds of provision which is provided. I suppose the most obvious thing to focus on in an answer would be to think about the significance of Catholic nuns and what they can do. And I think this was really highlighted in the 70s, that I think the Catholic provision in this time of gross collapse across the medical system was perhaps less than was found in the Anglican system, because Anglican missionaries often had families, had children, and their vulnerability was greater, and there was a greater decline in Anglican service in this time of risk, extreme risk, than the Catholic missionaries experienced. When I interviewed elderly nuns who had retired back home, they felt sad that they had retired home. They didn't want to. They wanted to be buried in Uganda. There was a sense that that's where they wanted to be buried. So I think the cheapness of being a nun, you've no family to support, the sense that they are solitary individuals and that they have a calling to almost be sacrificed, as some of them thought, was distinctive. So in that particular way, the difference is very marked. I would say, though, that the competitiveness of missions meant that they tended to replicate what the other was doing. So when the CMS, the Anglicans, started to develop maternity centres and child health centres, then within a few years, the Catholic Church was approaching the Catholic missionaries in Uganda were approaching the Vatican saying, we need to replicate this, and the way to do it is to have nuns doing it. And at the moment, we are not allowed by the Vatican to do this. So they pressured the Vatican to change policy. So this was to replicate what the Anglicans were doing because they didn't want the Anglicans to get ahead of them. So it works in different ways in different periods. Thank you.
We have a question through sorry, please.
I'm just going to say, could I just add to that? Because I think one of the reasons that there's a reticence among some groups to engage with the faith-based service providers is because they're largely Christian, and governments and international organisations need to have a demonstrable, relationship with both religions, particularly where it's Islamic and Christian, and where that's a part of a conflict in a country. So one of the things we've been trying to do more recently is reach out to the Islamic medical associations and build those links and strengthen that engagement. And I think the Christian health associations have also recognised that if they have that interfaith partnership with their Islamic brethren, then they're more likely to be able to engage with governments and with other organisations. So I think that's an important piece, particularly, as you say, where Christian-Islam tensions are part of a national sort of psyche order.
So we have a question from Ben Walker at the University of Cambridge, who asked, how far do you think that standardised global public health programmes can be and have been adapted to local cultures with medical missionaries, especially at a time when someone in the WHO are questioning how culturally relative healthcare should be?
Are compared with those certainly who are planning these programs out of Geneva, but often even those who are planning them out of capitals in the countries. I remember very clearly in Nepal, when we were working in the even district level, but also in the local level, our sense that the capital was alienated from the local situation and just simply didn't understand. And a lot of the program design that we saw coming out of Kathmandu was just so completely unrealistic. It didn't appear to take into account the local context, whether that was an infrastructure context or a cultural context. So the fact that there are many medical projects at the community level, I think answers that question. Yes, of course, they are going to be very important in helping to adapt global programs to the local culture. I think too, though, that we probably need to look at this in a somewhat differentiated way. There are some global public health programs which arguably are implemented almost the same anywhere you are in the world. And I'm not going to I'm not going to fall into the trap of saying what those programs are, but let's say that there are some which are more readily standardized, and there are others which clearly do require much more of a local understanding of the culture. The delivery particularly of treatment to stigmatized populations, and HIV, TB, for example, is going to be, and leprosy, is going to be very different to the delivery of malaria, which doesn't tend to carry the same stigma and therefore require the same understanding of the local culture. So I think it's not necessarily true to say that it's across the board of all global health programs, but certainly there are some where an understanding of the local culture is much more important than others.
to add two brief things to that answer. Going further back in time, in the earlier parts of the 20th century, there was an issue of missionaries often having preconceptions about African sexuality or hypersexuality, which was shaped by a missionary context. And, for example, there was a tendency, as I mentioned, to overdiagnose STDs by missionaries. If you compare missionary disease incidence records with secular disease incidence records, then you see that STDs are much more commonly diagnosed in mission institutions than in the state ones. And yet, if I was a patient who thought I had an STD, I would not go to a missionary institution, for I knew what I'd hear, that I'd been a very naughty person. Whereas the state system didn't tend to criticize people's behavior. So it suggests to me that there's an overdiagnosis, a systemic overdiagnosis in the past. And there are two particular individuals who are extremely impressive doctors who went as medical missionaries to Uganda. And within a few years, they left the missionary system because they believed that STDs were being systematically overdiagnosed and their colleagues would not listen. So they left and they did really important work in other fields. And that to me is quite suggestive of how cultural adaptation is not always so strong within the history, the kind of deeper history of mission medical provision. On the other hand, the cultural knowledge of mission medical personnel in the past was evidently much superior to state people who tended to come in and not stay as long as missionary personnel. So you often read the stories of individual missionary medical personnel who work in a hospital for maybe 30, 40 years, and they are completely fluent in local vernaculars and so on and so on. Where their personalities are, if you like, open to adapting what they provide to local culture, then I think they do really, really impressive work. Where they are not, then it's not so good.
Thank you very much. It's really comments rather than questions. My name is Erica Whelan. I'm from the Department of Health Workforce, and in a way I'm responding to what my colleague there was saying about the role of WHO, and to say that I completely and utterly agree with the fact that WHO needs to be working much, much more than we do with medical missionaries, with NGOs that provide faith-based services, and in our department we do. In fact, we have, for example, we have a project now that's working with Seventh-day Adventists in maybe about 5 countries, and they deliver services, of course, to local communities, including to people who suffer from HIV/AIDS. So we have embraced it. I'm not saying we're perfect at it, but it's certainly something that we are doing. And I also wanted to share something more recent, which is taking a slightly different angle. It's not just about service provision, but it's how you address the education of health workers to be able to take on board, I would say, spiritual issues when they have patients coming to them. And because my area is for education and training in the team, it's something I've been working on, and we've worked with a global group of people to produce an evaluation tool to assess the education of health workers. So this is globally, and in addition to asking questions about the kind of psychosocial, biological aspect of the training of health professionals, we've actually included spiritual needs. Are health workers, when in their pre-service period, are they actually being told the importance of the spiritual needs of their patients? So this is going to be a global tool, so we will be collecting information on this from around the world. So not just focusing on maybe rural missionaries, which is what we're talking about, but for me it's also about how do we spread this attitude of taking on board people's spiritual needs in a much broader way, that it becomes almost like a routine and normal thing that people are being trained to look for and address and know how to deal with. So that was my comment. Thank you very much.
Thank you, Dr. Smith. I am an NPO from Nepal office, and I happen to be here in one of the meeting in RHR, and just was attracted by this whole lunchtime seminar because I happen to work for HIV, as well as now I work for universal health coverage and health planning. So I was attracted to this whole seminar. When I came here, I was thrilled to know about Nepal presentation was being made. Thank you so much. Last question really provoked me on speaking in this forum, and the reason how WHO's standards are being followed is we adopt in the country's level, and the mission hospitals have really worked out fine. Like I can name two, Patan and other in Palpa Mission Hospital, who have really adopted the whole standards of all the curriculums that we have made, and which has been adopted by the country. And now Patan has been given out to the government, and it runs as a semi-autonomous at the moment, which are beautiful examples of how healthcare has been developed through the mission support in Nepal as well. I myself have worked in an Seventh-day Adventist in a PhD level with Adra Nepal in Banipa, where I delivered in PhD myself government standards of STI treatment and HIV treatment from that level as well. There are opportunities in universal health coverage, how we can really focus on how to use these missionary hospitals as well. Thank you.
Thank you very much. Isabel Nital, Alert and Response Department. Well, first of all, thank you so much to the three presenters. This is really, those were fascinating presentations. A few comments as I'm trying to see how we can take forward what we've heard, because it's really good to hear, and we want to see how it can be further used. So what I noted is that there are a couple of excellent evidence in the presentation of the impact. And as you know, WHO is very much evidence-based organization. So we need to build on this evidence, on the performance and service delivery by the faith-based organization to be better positioned. Second, universal health coverage, yes, but all WHO programs for me in a very naive way. There is no reason to limit to only universal health coverage, which is perceived now as being taken by a certain part of WHO. All programs, whether they're vertical or horizontal, whether they're surveillance, whether they're non-communicable diseases, they can all benefit from expanding their outreach to the faith-based organization. And third is, so therefore, this is a great audience, but I do regret that I cannot see any of my director colleagues, except one in the room, I think, and so we need to expand that. A few that I may not know, apologies if I didn't recognize them. So I think that type of discussion should take place also with a different type of audience who needs to be better informed, because those who came have probably some bias, they're already interested, and the others who would naturally not be interested are not here, but need to know better. Fourth point is maybe in the current WHO culture, where a lot is being discussed about conflict of interest, one could also look at that in terms of declaring a conflict of interest. It could be seen that working with a faith-based organization has some conflict, could have potentially conflict of interest. Let's just be transparent and declare that, and declare, and also invite experts, having them declaring where they're coming from, so that it's very transparent. We do that with the pharmaceutical industry, and it seems natural now for a lot of us to invite experts, and they declare their interest, and there is no conflict, they're just recognized. So these are elements for future implementation, and in particular based on the success on HIV and Ebola. I think we have a momentum now to build on that in the 3 countries under the recovery phase, so that from the beginning of the recovery we expand with the faith-based organization, and don't miss this opportunity right now where we're building new plans. And I stop here. Thank you.
Thanks, Isabel. That's great. I had a similar thought around the declaration of interest. And in the HIV field, a number of the NGOs came together to do no harm kind of standards of good practice. And they agreed together, these are the things that we will adhere to, and then a whole range of organisations signed up to it. And I think you could do a similar thing in the faith-based setting. So, for example, we've already got some of those things in the UNAIDS framework for engagement with faith-based groups, and there were roles and responsibilities for the faith-based groups and for the international organisations. So, for example, not using international funds for proselytisation was one that the faith-based groups agreed to, and not undermining scientific evidence publicly. Similarly, the international organisations agreed not to undermine religious belief publicly. So to have that kind of list of things that we agreed to, there's a starting point there.
Thank you very much. A very interesting presentation, and I think I take what Isabel says about the follow-up of this very important area as what Shambu said. To declare my interest, I'm born a Hindu. I was brought up as a Muslim. I ended up running mission hospitals, Catholic mission hospitals. And I worked as a government civil servant for many years, supporting different missions, health services. I think the problem is the questions are, it's so nice to see the history of primary health care and the great leadership in public health over the last 30 years. I mean, from Maurice King to Morley to, I think it takes us, Maurice King was, if you talk about Uganda and health services in Makerere, but why the mission attitude in healthcare delivery is being lost, or has been lost, whether it is in a mission hospital, whether it's in a government hospital or government service, why we are losing that. This is a learning from history. The missionary attitude, whether it's good or bad, it actually provided service delivery to people in need. So that's one. The second is primary health care united everybody. And this is something universal health care has to learn. I think is something maybe we need learning from the history point of view. And then really we need to address why the missions have been crowded out between government. And the answer is very simple. It's the way international financing has crowded out. And international financing doesn't recognize the faith-based organizations adequately. Care. So I think we need to maybe, as you said, maybe take this forward in a systematic way. The gap is because so many other people are working with governments and pushing out and are not recognizing enough the faith-based organizations which are really there as a bedrock of. My name is Shiva, thanks.
And you work for the
Yeah, declare now my whole life. Yes, I work for malaria and yeah, that's right. Yeah, okay.
I forgot myself. So, thank you so much for joining us. Thank you to the speakers. I think this model of having three speakers really worked well. I hope we can follow up and do more things. I think there are some very important questions that have come up. I think this has real relevance to Ebola response. We need to think about this. I'd like to thank all my WHO colleagues, including Pro Jing, whose voice has deserted her today. So she's in the room smiling, but you haven't heard her voice today. Human, an ex-colleague who stepped in. Our funders, the Wellcome Trust, without their support, none of this would have been possible, at least from our side. And all of you for joining us and your comments. And the recordings are very, very important for students, and we hope for WHO interns and new employees as well. So thank you all for coming.